Welcome to Raaonline. So today we are going to see the topic on acute enteritis. To be specific, we are going to see on Clostridioides difficile infection. So now this Clostridioides difficile is an emerging superbug and one of the leading causes of nosocomial infection. As an emergency physician, we must be knowing about this Clostridium infection because nowadays the healthcare has been more open to the general public and there are a lot of admissions happening. So if you come across a patient who is presenting to you with the loose stools, you get a history that the patient was recently admitted in a hospital, who has taken a set of antibiotics and now coming with the loose stools, always suspect this could be a Clostridium difficile infection. And at that point of time, just escalating the routine antibiotic can be even harmful for the patient. You might even kill the patient. There is around 20% mortality rate in Clostridium difficile infection, right? The basic understanding about a medical profession is do no harm. But a patient who's coming to you with the loose stools, if you prescribe the regular antibiotics, then there's a chance that 20% mortality rate can be there, right? So whenever you see a patient with loose stools, you need to ask a proper history, identify can this be a Clostridium infection. In that case, your regular antibiotic should not be used. The identification, the diagnosis of Clostridium should be done at that spot itself, and then the treatment should be started appropriately because this infection can spread among the family and to the community, right? Fine. So this Clostridioides difficile is an emerging superbug and one of the leading cause of nosocomial infection. This is renamed as Clostridioides difficile in 2016 to reflect that taxonomic difference from the other Clostridium groups as such. Basically, the transmission occurs through the ingestion of spores through the fecal-oral route. Okay, reinfections occurs again and again. It can be debilitating because incomplete treatment can cause retaining of spores in the gut, which will produce more amount of recurrent infections. Or if they are continuing the same type of antibiotics which caused the Clostridium difficile to flourish, if you continue that set of harmful antibiotics, again there could be a reinfection, right? So the major point is identify this enteritis as not a routine enteritis, identify this enteritis as Clostridium difficile enteritis, and you need to stop the antibiotic as a treatment and you have to continue a proper set of antibiotic for Clostridium per se. Epidemiology, right from 1940s, we are aware that there are some amount of colitis going on into the patients, but not until 1978 that we were able to identify that exposure to clindamycin followed by exposure to penicillin or cephalosporin, this amount of colitis was more and possibly because of this Clostridium species. Somewhere in 2001, 2003, 2006, there were more frequent and severe form of refractory infections in the Western world. That's because of a new type of Clostridium difficile infection, which is Rebotype 078, which has affected the younger population. Okay, this was because the use of fluoroquinolones flourished in 2005. Just because the fluoroquinolones flourished, this has promoted fluoroquinolones. This has promoted the growth of this type of particular Clostridium difficile, which is Rebotype 078. Okay, the new strain NAP1B1027 is also on a very increasing scale. This is also because of increased fluoroquinolone use, and it's associated with increased toxic production, and it's associated with recurrent infection as well. What is the meaning of nosocomial infection? Is it is acquired after 7 days of hospital admission. Okay, 2 to 20% of patients are colonized during hospital stay. What is the meaning of community acquired infection? It means that from the time you diagnose the patient, the patient was not hospitalized for the prior 12 weeks. So it's called as community acquired infection. Basically, the patient was in the community for 12 weeks and then has acquired an infection. Then it's called a community acquired infection. And that could be exposure to domestic animals, retail food products. Why specifically they mention is these type of antibiotics is not only used for human healthcare system. These antibiotics like clindamycin and other stuff are used for animal husbandry also. So the Clostridium difficile is more common in animal husbandry, and those spores can be transmitted to humans by fecal-oral route for those people who have exposure to domestic animals. Okay. So what is the meaning of recurrent infection? Resolution of symptoms followed by reappearance in 2 to 8 weeks, that is within 2 months. after the completion of treatment is called as a recurrent infection. Relapse means with the same strain. Reinfection is with a different strain. What's the meaning of relapse? In the gut, the spore is still persistent and you have not treated it adequately. Then it's also called as a relapse, or you have treated it adequately, but again you have restarted the same set of antibiotics which caused the flourishing of the spores. So again new type of spores have developed. This is also a relapse. So what are the basic risk factors? So you see a patient who has come to you with loose stools and you check for recent hospital admission based on this definitions. If it's going to be nosocomial, it's after 3 days of hospitalization. It's going to be a recurrent infection. Ask for any loose stool episodes within the prior 8 weeks. It's going to be community acquired infection. Ask whether the patient was admitted in the prior 12 weeks. Okay, then you're going to check for risk factors. The overall risk factors is like antibiotic use. Almost any antibiotic use can affect the normal microbiome of your gut. And there are more likely chances for particular group of antibiotics, less likely chances for other particular group of antibiotics, which we'll see little later. So antibiotic use, advanced age, basically I'm saying over the decreased immunity, hospitalization itself, severe comorbid illnesses, gastric acid suppression, GI surgery, enteral feeding, cancer chemotherapy, and IBD, inflammatory bowel disease, and cirrhosis. And recurrent infection, the age is more than 65, need for ongoing antibiotic treatment during CDA treatment. For example, you have started a patient on an antibiotic and following this antibiotic over a period of 10 days and you see the patient's developed loose stools and you confirm it's going to be a CDI, you need to stop that offending antibiotic, right? But if the primary illness demands that particular antibiotic itself along with your CDA treatment, then the chance of recurrent infection is going to be very high. Hope you got the point. For example, a patient started on a drug called as drug A and you are continuing for a illness, and you are continuing this drug for maybe 10 days, okay? So at the end of 10 days, you see the patient has loose stools and a confirmed Clostridium difficile infection. So when you confirm a Clostridium difficile infection, you need to stop the offending antibiotic, right? But if this illness demands to continue this antibiotic along with the CDA treatment, then there is a chance of recurrent infection. And depending upon the strain type, whether the patient is immunocompromised or not, lack of antibody mediated immune responses to toxins, because it is the toxin immune mediated responses is available in a healthy individuals. That is why in some people who have adequate immunity, even though they have this kind of toxigenic strains of Clostridium in their gut, they are not showing up any symptoms.